Part two, we're actually going to talk about government intervention versus individual liberties. We're going to look at some ethical considerations. We're going to talk about Schneider and Ingram's social constructions and who gets the benefits and who gets the burdens. And then we get to do a really fun little case study, so you'll have something more fun to do. All right, so let's go ahead and get into this first section. And like I said, once we get through this first part, then we'll go ahead and take a short break. All right, so at the heart of public health law is really the need to balance government intervention and individual liberty, okay? Because governments have the power to protect public health, but the US Constitution has actually not been interpreted to require federal, state, or local governments to actually assure communal health, okay? And that's always a big kicker to, my public health students always say, what do you mean? What do you mean? It's not in the Constitution, but if you think about it, it's not. Right? We don't have any constitutional something that says that government is required to provide public health. Right? If you look in the preamble of the Constitution, that notion of general welfare, that could be public health. So basically, when federal government or even state and local governments wish to intervene in public health, they're using that kind of idea that that's part of the general welfare of the population. But there's nothing in our actual Constitution that says we're required to provide public health. And that's why it's so much more difficult for us to get those policies through, because we have to convince people that it's in the best interest of the population to do so, because constitutionally it's actually not mandated, okay? And so here's where we're gonna see a lot of disconnect. And this section, like I said, gets a little bit dry because it's government and politics and you guys are like, oh, but it's very important. And I think this is a perfect opportunity for us to sort of look. As we're going through this pandemic, I've had several of my students, and I assume, and I know some of my family members, and I'm assuming some of you have said, why all the disconnect between the federal government and the state governments? Why are localities doing things different? It's because of the way our government is actually set up, okay? As much as it seems completely chaotic, and it is partly because of the pandemic, and we don't necessarily know what we're doing, right? But really, at the heart of it is the structure of our government and how that works and who has what power to do what. And so I think as we go through this, if you think about what you've seen during the pandemic and the different levels of government and what they've done, you're gonna see that it sort of aligns with what they're supposed to be doing. And maybe that's good and maybe that's not, but I think it'll be a really good way for you to sort of see it. So this part won't be as boring if you start to think about what I'm talking about in the context of what you've seen the responses are for the pandemic. Okay, so of course we have 3 levels of government, and then the tribal, of course, is its own thing, right? All of you who live in Montana are very familiar with the idea of tribal and the fact that they have their own thing. So we're going to focus more today on federal, state, and local. And I know a lot of you do actually work with tribes, right? And that's a whole other monster. We could spend an entire class just to talk about tribal policy and how we interact with that group. But what we really want to look at today, like I said, is who's doing those things at those 3 levels, and why is it that we're getting policies sometimes from federal or from the state? When do we have the option to be able to do our own thing at a local level? And so again, we're back to thinking about the difference between government intervention and individual liberties. And our Constitution, if you know your Bill of Rights, which of course I won't pull you on that this morning, the Bill of Rights really basically is going to let us have all these individual liberties, right? We have free speech and freedom of press and freedom of assembly and freedom of religion. We have all these freedom, which is great. But then when the government's going to come into this, right? When the government's going to interact with this, you're going to get pushback anytime that we're going to step on individual liberties. And of course, with public health, that's all we're doing, right? If we're trying to make a population healthier with our policies and programs, literally we're telling people they need to change their behavior, right? Isn't that what we're doing? So clearly there's going to be a pushback for this, right? All of us can think of a great policy to fix something, but it would require absolute restriction in that process, right? And that's just not part of what the American ideal is. So it makes it a whole lot more difficult for us to get policy through. Okay, so let's just start to look at the national government, all right? So federal government has very specific powers. For the most part, they're powers that are given by the Constitution. Okay? There is a little bit of leeway here in what's called implied powers. Sometimes Congress is given that, oh, this is what this means, but mostly the federal level is limited by what the Constitution says. In other words, they have things to do like tax and spend, and they can regulate interstate commerce. So here's one of the ways that we see. For example, marijuana is illegal, right? Because the federal government labeled it a Schedule I drug. Well, the question is, do they have the ability to do that? And they do, because the Supreme Court ruled that marijuana is interstate commerce, and Congress has the ability to regulate interstate commerce. So when states are trying to make marijuana legal, they actually can't do that. They don't have the power to actually do it, right? So again, I teach here in California, where marijuana is now legal supposedly at the state level. And of course, I teach a lot of undergrads here in the state of California. So I'm always really careful to make sure they understand that even if a state says it's okay, if they don't have the authority to say that, if let's say there's a federal officer standing there, right, that they can still arrest you because marijuana is illegal, because at the federal level, Congress actually has the right to regulate that and not the states. Now you might ask, why would the states pass these laws when they know they can't? Well, sometimes it's because legislators don't even actually understand that they can't do that. But mostly it's because states are trying to get the federal government to act. So if enough states start passing this, legalizing marijuana, then the federal government will have to come back and reconsider. And so typically they're doing that as a, hey, we want you to make some sort of move here, federal government. And so the states are pushing to get that done, okay? The president also has powers, not just Congress. He has powers under his commander-in-chief hat, right? So commander-in-chief, we think of military, but anything that's protecting the population is considered under that commander-in-chief, right, to protect the public. So when President Trump issued that nationwide stay-at-home order or a travel ban, that would fall in that category. So if he said, okay, we can't have any travel outside of the United States to this country or this country because of the pandemic, he can do that with his commander-in-chief power. Now, again, when I said he could issue the nationwide stay-at-home order, some of you are thinking, but all states didn't do that. Exactly, right? And where does that pushback coming from? And so we'll see that as we move through the next levels of government. All right, so the next one is the states. Now here's really where the power is, okay? A lot of times locals will have some power and you're able to do so, and it depends on the state. But really, like I said, federal government is so limited by the Constitution, right? Whatever is not given to the federal government is reserved to the states via the 10th and the 14th Amendment, right? The 10th Amendment said if it's not in the Constitution, then the federal government doesn't have it. When we created this country, we wanted that strong sense of states' rights, right? We had just come off a monarchy, and the last thing that we wanted in that kind of situation was to have another monarch. So they were really limiting the powers of the federal government. And so for this, if it's not in the Constitution or an implied power, right, the courts have ruled that that's not under the purview of the federal government. All of the rest of it is left to the state government, okay? And so state governments get that authority to actually create policy through two different things: police powers and parens patriae. Police powers and parens patriae. So let's talk about the police powers. Now, of course, unfortunately, in the state of our world in the last few weeks, police powers makes people a little bit nervous, but this is actually more than law enforcement, okay? When we talk about somebody's police powers, they're really broad in scope, and they really represent the state's primary source of power to promote the general welfare of society. Okay? These police powers have been defined as the inherent authority of the state to enact laws and make regulations that protect, preserve, and promote health, safety, morals, and general welfare of the people. Okay. Even in 2006, the Supreme Court noted that principles of federalism allow states great latitude under this police power to legislate for lives, limbs, health, comfort of all people. Okay, so the Supreme Court has even ruled that yes, in fact, these police powers do give the states the power to create policies that will impact public health. Okay, so this is an original source of public health law designed to prevent morbidity and mortality across populations. So police powers support public health measures for testing and screening, for vaccination, to treat people, to quarantine, and to isolate. We're going to talk when we get later about actual social distancing policies and why that is allowable for us at a public health level. They authorize creation of state and local public health agencies and empower them to conduct educational campaigns, surveillance, investigation, right? Now, states can restrict private interests in liberty, autonomy, and privacy with these police powers, okay, as long as it's justified. And we're going to talk about at what point any of the levels of government, whether it be state, federal, or local, when the court might say that you've gone too far. Okay, so we'll look at that in just a few minutes. But for now, we're going to go ahead and look at that parens patriae. Parens patriae, that's a Latin term that actually means parent of the country, but it's used here in this as the country being the state, right? The state of, so the parent of the country. So parens patriae allows states not only to act in the interest of the community, but also in relation to individuals' own best interests. So it's this combination of community and individual, which is really difficult, right? Because what you're going to do is, if you're trying to make the community healthier, you're going to have to step on that individual liberty a little bit, right? So there's two major ways that we can use parens patriae powers. In the first one, the state might seek legal standing in cases that support the community's health and welfare, right? So let's say, for instance, the state sues the federal government on behalf of its citizens, compelling something specific like EPA protection to regulate greenhouse gases. So if states have said, hey, federal government, you're not doing enough, our people are suffering because of greenhouse gas, we need you to do so. So that's one of the things that they can do under their parens patriae, because they're the parent of the state and they're saying, hey, federal government, do something. The second one is that the state may serve as guardian of or provide protections for people who might otherwise lack capacity to look after their own interests, right? Or their own welfare. So they're allowed under these parens patriae to protect a child from mental or physical abuse or neglect. They're allowed under parens patriae to institutionalize a person with mental instability who poses a risk to him or herself. And they're also allowed to prevent harms to incapacitated older persons from their caretakers. Those are just three of the things, the ways that states actually use parens patriae. So this gives states a lot of power, right? Because here's the cool part. Again, national government is limited by the Constitution. Everything else goes to the state. Now, the state can keep all of that power to themselves if they so chose. The state could make every health decision, every legislative decision that they wanted to if they so chose to do so, okay? But a lot of states actually give some of that power to local levels, right? Local governments, local areas, local boards of health are actually the ones that are able to implement these policies and sometimes make their own policies, right? Again, they do have power. Now, of course, local are limited, that they cannot supersede state or federal guidelines, right? So here's just a quick look at local health departments, right? This is a really cool little map taken from the CDC. And of course, we know that our county and city and local public health officials, they're on the front lines of public health practice, right? You're directly responsible for conducting public health surveillance, for implementing public health programs that are funded by federal and local governments. You operate health clinics, you set public health policies. Performance of local public health agencies is also evaluated with national standards, right? So local government's authority to act extends largely from a broad or narrow delegation of power. So this map actually shows us, if we look closely here, what we're seeing in this particular map is if there's a mix here. Notice all the states are not the same. So we started to see, this is when local departments do something different, right? So for instance, in Montana, right, this is very decentralized. What that means is that each of the local areas has been given power from the state, so they sort of have their own purview, right? An interesting thing, at the end of my spring semester, one of my classes, they were supposed to go and listen to a local health department to actually see what policies they were talking about. Well, of course, with COVID, everybody was doing that, and also their meetings were not in person, they were via Zoom. One of my students actually was able to attend 2 different meetings for 2 different county health departments, okay? And her response was, oh my goodness, they're going about this so differently, whether they're gonna close down or whether they thought they had authority to do so. This one said, let's hurry up and close down. This one said, we're gonna wait and see if we need to. And she asked, how is it that they can be so different? The counties were side by side. Well, they can do that because Montana is decentralized, right? So the state says, okay, you guys have this different powers, and then the localities are able to make their own judgments to an extent, right? Again, once you get to the part where you have governor's orders and how do you follow that, again, deals with how much local power everybody has. So local government's authority to act in the interest of the public's health extends largely from those powers, right? And what we call that is home rule over public health matters within your jurisdiction. Home rule is premised on the idea that the local government actually understands better than the state or the federal government what their people need, okay? So state legislatures, though, can take this away from you, all right? It's called preemption. They can remove home rule at will unless it's protected by provisions embedded in the state constitution. So just because a state is decentralized doesn't mean the power for local authority is the same for every area. So here's a good example. So look at Illinois. If you look at the map, Illinois is the same color as Montana, decentralized, right? And most of you have probably heard about Governor Pritzker because he's been in a nice little tweet war with the president over the past few weeks. The president telling him to go ahead and open back up. Of course, Pritzker's got the city of Chicago in the state of Illinois, and so his cases were going up, going up, going up. So he issued a stay-at-home order. And of course, the people in Illinois, like a lot of people in a lot of states, challenged this idea immediately. And then 1 of 2, 5, 6 of the different legislators in the state started looking at the Constitution for the state. And when they did so, they came upon a nice little clause that showed that the governor could invoke a stay-at-home order, but only for 30 days. Okay? When the 30 days was up, they expected Pritzker to lift the stay-at-home order. Well, he didn't. Okay? And at that time, a lot of local communities said he no longer has authority to tell us to stay home, and they began to lift orders within their communities. But in my hometown, which is in the middle of central Illinois, okay, a town of roughly 12,000 people, there were calls to the mayor to open the city, right? They were like, what, open up, his 30 days are over. Well, the mayor actually had to come and explain then through the newspaper the idea of home rule. And he said that that city does not have home rule. And so they can't go against the governor's stay-at-home order. Now, again, you're saying, well, if he only has the power for 30 days, but a court hadn't ruled that he had to stop at that point. So the mayor of my hometown said, we don't have home rule, we're not allowed. But some of the smaller little cities around my city were able to do so because they have home rule. And so people were very confused because they didn't understand why our mayor was following this governor's orders when they thought the governor no longer had the capacity to do so. But it's because the city did not have home rule. So here's how we sort of think about this. Local government's home rule may be limited even by the courts, right? The court started to rule with this way back in the 1800s, and it's known as Dillon's Rule, the Supreme Court justice who actually wrote the opinion for that. And it says local governments are limited. Basically, he was arguing that the locals can only do what the state specifically tells them they can do, right? But what we've seen is that's not been the case. We've seen it go the other way around. And basically, as long as it's not restricted by the state, you're allowed to do it at the local level, okay? So in 2001, the Tennessee Supreme Court actually said we're going to look at the legislative intent instead of Dillon's Rule, okay? Okay, so now we know that the national government, the state government, and the local governments now all have these different powers. So if we're thinking about it like in terms of pandemic, can we start to see what the president issues one thing, the state said yes or no, then the states actually either told their whole state, and even when they gave the states, sometimes they gave separate pieces of that, right? Not everybody, even within the state, had to do the same things. And part of this is due to this idea of what we call preemption, okay? Preemption. So this is an embedded legal theory in the US constitutional system, and this refers to how a state or local law can be averted or displaced or negated by a higher level of government, okay? So again, what it's showing you here is if you make a local policy and that goes against what a state or the federal would level, the federal government can preempt you. Okay. Well, what does that actually look like, right? So let's look at this nice little graphic here that shows us the preemption house, and this is taken from a public health law textbook by James Hodge Jr., right? And we're going to talk about 3 pieces here: the ceiling, the floor, and a field, okay? The field that goes around it. So with ceiling, you look at it this way: state or local laws that impose stricter standards than those at the federal level can be preempted if the federal standard is actually set to be the ceiling, okay? So if a state makes something that is stronger than what the federal level set, now it can be done if the federal government doesn't set it as the ceiling, okay? The ceiling, which lower level governments cannot exceed. So here's a really good example for us to understand the ceiling. The 26th Amendment to the Constitution sets the legal voting age at 18, right? States cannot go higher than that. In other words, a state can't raise the legal voting age to 21 because that rule that the Constitution set it at 18 is a ceiling. You can't go above that because the ceiling is set by the federal government, okay? But if we look to the opposite of that, sometimes federal law is set as a floor, okay? So if this is when the federal government gives a minimum that you have to get to, but you're allowed to go above and beyond that, right? So the government is setting the floor to this, but is not saying that you can't go above, right? So a good example of this would be Medicaid, right? States have Medicaid, but that's considered the floor because states are allowed to provide more benefits than what the federal level set, right? And several people have done this, right? If we look at this is 37 states that have actually expanded their Medicaid, including Montana now. Not that the voters got that through, right? But when that was actually signed by Governor Bullock May 9th of 2019. Again, there's a whole big debate on what's included in that and the 1115 waiver proposal. So we'll see, because of course that request is pending. But if we look at this map, we can see that certain states chose not to expand. They don't have to. They've met the floor by having Medicaid programs, period. That's the floor. But they're allowed to go above and beyond that if they wanted to expand Medicaid because the federal government only set this policy as the floor, okay? And the last piece we're going to talk about is the field, and that's what goes all the way around this. And so it might preempt similar state or local laws altogether, even if that federal law insufficiently addresses public health outcomes. So in this way, federal preemption can strip state and local governments of their ability to address public health issues. And we'll actually see a really good example of this when we finish our first case study today that looks at the SSB tax. Okay, so of course, preemption can be a good thing. Preemption can help. It can hinder public health goals. Federal preemption has been used positively to create the national floor, like menu labeling provisions, but also it can be used to thwart state and local government's powers to be able to do that. So one of the issues is like through maybe gun control or food policies or employment protections. States may want to do more than that, and the federal government says that you can't. Okay? So the federal government says that you can't. All right, so now that we've covered all that constitutional stuff, and like I said, hopefully you're seeing now where that disconnect comes between the federal government, the states, and the local, especially as we apply it to the pandemic, and why it looks like it's such chaos. It's because it actually is such chaos. And it's not to say that they're not. Again, part of it is that we didn't necessarily understand what we're supposed to be doing in a pandemic, and we're not understanding that virus as well as we need to. But a lot of it actually really has to do with the structure of the way our government is set up and who has authority to do what. All right, so we finished this section. Let's take 5 minutes and get some coffee and a break, and we'll come back and talk some more about the Constitution. Okay, hopefully everybody had time to get some coffee. Like I said, I'll stick with water so I don't talk any faster than I already do. We had a good question here in the chat box that Emily pointed out to me. So she said, this question is, what about health department employees working on policy process, or what's restrictions, right? So here's the thing. If you're not involved, who's going to do it, right? I mean, that's really the piece of that. You have to be, I mean, if we're not, we're just going to get policy passed by people who don't know what they're doing, right? This is my argument for that. Now, the only hang up would be is the part where you're having to actually deal with policies, like policymakers, right? You don't want to look like you're being political, right? When you're working for the public's health as a whole, right? So, and this may be a point where you're actually working with somebody who knows and understands that legislative process, and it can be the one then talking to those policymakers to get it through, right? But if you're not the one who's identifying the problem and looking at the different options to deal with that policy, and then getting that onto the radar of those people who can pass it, right? Again, you're going to just let them make policy that they don't necessarily know anything about. So I understand what you're saying. You're asking that part of it where it becomes political, like we're looking like, oh, this is a Democratic something, this is a Republican something. Yes, and again, you're going to have those people on board. And ideally, if you can have both sides on board, then you don't have that problem. But if it's not, if it's going to have to be something that one side or the other is fighting for, yes. If that begins to be uncomfortable, or that it doesn't, you know, you're not thinking, oh, as a public health employee, I'm supposed to be protecting all of public health and this looks too political, right? So that is where you can stop, right? You can get those people involved. But again, I would argue if you're not the one looking at the problem, and you're not the one who's actually helping to go through those policy options and push for a good solution, how are we going to get any better at public health for that, right? And even if you're doing something that's maybe at your state level or local level, right? If you think that there needs to be, say, a sex education program in your schools, somebody's going to need to go talk to the schools and to the parents, right? Who else is going to do that? You're the one who has the data and the information and the policy options that you can explain to them to be able to push that policy through. And if you're not the one there to do that, all the pushback from parents and then schools just saying, oh, we just don't want to cover this, we don't want to make parents mad, how are you going to get that into there? So you can get involved in that process, again, as long as you're not hitting that political wall that maybe makes you feel uncomfortable. And hopefully that answered your question. And maybe some of the rest of you have that same question. So, okay, let's go ahead then and look at this next piece. We're still in that whole public health law purview, but we want to look a little bit at constitutional individual rights. Okay, so there's our little preemption house that we had from before. We've added the tree, which is our separation of powers that says each area of government has a different thing to do, and federalism that says we're layered, right? One of the old things you probably learned way back in American government class was the idea of federalism, right? That the national, the state, and the local each have their own level of government, and it looks so pretty, like a layer cake. And then as we started to really learn about it, we realized it looked more like what they call the marble cake, because it gets all messy, right? It gets all messy. So how come it gets like messy like that? Well, part of it is because of this little fence we have here. This little fence in front of us is those constitutional individual rights. Okay, the individual rights. Notice here on this fence is things like due process and equal protection and freedom of speech and right to travel and right to privacy, all of those things. So now we've got this fence up here that goes on top of all that that says, hey, we as individuals in this particular country have all these individual rights, and those affect how government regulates the interests of public health, right? So the private sector doesn't owe individuals respect for constitutional rights whatsoever. The government actually can't infringe on fundamental individual rights unless they have sufficient reason, okay? So constitutional rights are not absolute. They are subject to constant balancing under various rules and tests, and the Supreme Court has done a pretty decent job of developing different levels of scrutiny or standards. Now, who they put in those categories is sort of a piece of contention, but they do have different levels of what they call scrutiny. And the Supreme Court and other courts actually apply in assessing potential infringements of individual rights, depending on a bunch of different factors, okay? So let's just look at the different levels of scrutiny that the Supreme Court has outlined for us. So this is the constitutional levels. There are three, what we call strict scrutiny, what we call intermediate or heightened scrutiny, and then the last one is rational basis. So if you hear somebody say, oh, it's the rational basis test, these are the kind of things that they're talking about. These are the levels of scrutiny. So what that really effectively means is that, and this is important to us, okay? You're thinking, why in the world are we talking about the court and all these different levels of scrutiny? Because when we go to create a policy and we want to get it passed, part of what we have to think about is, will it stand? Legally, have we done the right thing? Have we looked at how the court's going to look at this policy? And have we entered one of these spaces? Is our policy going to be able to stand up in court, or are they going to throw it out because we've moved up as far as scrutiny goes? Okay. So the top one there, that's the highest, right? That's the strict scrutiny. When fundamental rights like bodily privacy or suspect classes. Now classes in this case, if you see on this, it's race, ethnicity, alienage, or national origin. If those are implicated, then the government action has to be narrowly tailored to serve a compelling government interest, and it has to represent the least restrictive means for accomplishing the objective. So if you're dealing with any of those things, okay, it's exceedingly difficult for government interests to prevail. They're typically struck down by the courts, okay? So if a public health regulation or policy discriminates openly, or what the court calls on its face, if it discriminates openly against people on the basis of race by denying them access to public health services, that's going to fall in that level of strict scrutiny, right? So, and this is an old case, but in 1900, there was a devastating hurricane in Galveston, Texas, that killed thousands of people. And essential supplies were reportedly distributed first to the city's white citizens. And whatever was left every day was later given to their African American citizens. So a law or a policy like that is contrary to equal protection principles. And of course, absent a compelling government interest, which is highly unlikely because it was patent discrimination, would be considered unconstitutional because that policy, that what they were doing, was based on race. Okay, and you're not allowed to do that. So anytime we're dealing with something when it goes specifically for a race or a suspect class, ethnicity, or putting them in a category of stuff themselves, it's probably going to have a problem in the court. Okay. The next level is what they call intermediate or heightened scrutiny, right? It's heightened scrutiny. In other instances, government actions or laws implicate individual on grounds of gender, legitimacy of birth, sexual orientation, or other bases. Courts will assess whether there is a substantial relationship with important government interests, okay? Now, meeting this standard is easier than the strict, okay? But we have to be really careful. Notice the difference here. Notice that race is covered under strict. But ladies, where's gender? Oh, gender is only heightened. And so is, by the way, sexual orientation. Those are not in that strict level. So that means that there are policies that can get passed, not at that strict level, but in this more intermediate. Okay? So in some cases like this, here's an example. Implementation of maternal health services. Public health agencies may have sufficient justification for discriminating on the basis of gender. So way back when, in 1974, California Disability Insurance because men and women are not the same. In other words, you don't have to provide for pregnancy because gender doesn't matter. It's fine. We can discriminate against the women because they're not the same. Well, of course, Congress later prohibited pregnancy discrimination in 1978. But initially, and it was because gender is not held to that strict standard, it's just the intermediate standard. Okay. And in 2015, when the Supreme Court looked at the gay marriage, the right to marry for same-sex couples, some scholars thought the court might reason sexual orientation as a suspect class and move that into strict. Now, the court actually did not move it, okay? It's still in that intermediate level, but they said that violations of due process and equal protection were enough to overturn that, to allow same-sex couples to marry. But they did not move that up to strict scrutiny. So in the actual court proceeding, they didn't. So they're still in that intermediate with gender. All right, so rational basis, this is basically like the floor, okay? In a lot of other instances in which government actions infringe on individual rights or interests, there's just a minimal level of scrutiny applied. Governments need only demonstrate that there is some sort of rational basis for what they're doing, right? A reasonable relationship to a legitimate government interest. When you contrast this with strict, whenever courts employ the rational basis test, usually the court will say, okay, this is not a gender issue, this is not a race issue, this is not a sexual orientation issue, so we're going to be able to use rational basis here. And then we're going to say, okay, let me look at the law, the legislative intent and purpose, right? And that's what they're going to look at, separation of powers. The court doesn't like to interfere with the legislative process unless they absolutely have to, okay? So they're going to go with that under the separation of powers. So long as government can show a legitimate purpose, then the individual rights can be curtailed. So as a result, public health laws measured under this standard usually survive. So if you're creating a policy and you're not dealing with those top two, and you can show it's a legitimate interest to public health, your chances of it passing through a court system are going to be a lot easier because you're going to hit that rational basis test, okay? Like for instance, the Supreme Court might even, sometimes they tweak it, like they get a little more strict, but it's still rational basis. The city of Cleburne tried to make a local zoning ordinance saying that you couldn't put a mental institution within the community. Well, the court said they couldn't do that because there was no legitimate government interest to do so. So it discriminated against those persons with mental disabilities. Excuse me. So those, again, that was rational basis, but even then the court said, okay, but you can't you can't do this. You can't just, there's no legitimate government interest here for you saying you can't have a mental institution in that local community, okay? So now we've talked about these 3 levels of scrutiny here, and what are we doing with those, and who lines up where, and how are we gonna get our policies passed? So part of what you're doing then, as you're looking in that policy analysis section, right, you're looking at the different policy options, you have to think to yourself, okay, wait, first of all, who has the authority to do so, right? Is this a national government? Is this a state government? Can my local government do this, right? Then you have to ask yourself, okay, does it involve any of these suspect classes with race? Is it going to be under strict scrutiny in a court? Ooh, is it deal with gender, or does illegitimate children, or quasi-suspect classes, which is what we consider sexual orientation? Okay? Or is it just a policy we want to create for everyone in town, right? Is it doing that? And in that case, do we have a legitimate government interest here to do so? Then we're going to be at rational basis. So it's really important for us to understand this law part of the deal, right? Because if we don't understand how these are going to come out, we may easily create a policy that puts us in one of these categories, and then again, it's thrown out. We do not want to go through that entire policy process to get something implemented to have it thrown out by the court if we can help it, okay? So that's really the importance, and that's why we're covering it today, because when you're developing policy, right, you really need to look at those options and where are you at. And we're going to see sometimes in our case studies where sometimes people paid attention to that and sometimes they didn't. And what happens when you don't pay attention to that court piece of it, okay? So let's go ahead here and do a quick poll. I'm going to give you 1, 2, 3, 4 questions here. Pick which level of scrutiny those are. Well, we'll just go through them. How about that?
That works.
So number 1 is, which level of scrutiny is gender? Right? And let's just go back here for those of you who may have forgot, because I took that away from you, right? Gender is in that intermediate, right? That heightened. Remember, it's not at the top, it's not in that strict. If we look at number 2, though, the level of scrutiny for race is in fact strict, right? And sexual orientation falls in line with gender at intermediate, and stay-at-home orders actually is rational basis, right? It's a rational basis. And why is stay-at-home order a rational basis, right? Because it's for everybody, right? It's not based on race, it's not based on gender, it's not based on sexual orientation. So that means that when they say, okay, everybody in the whole county has to stay home, that would be a rational basis test. And a court would look to see if the government had a legitimate interest in doing that, right? And of course, if it's to protect population health and to lower the spread of COVID-19, that would be considered a legitimate government interest to do so, right? So there's that rational basis test for that. Okay, so, and of course I threw that one in there on purpose. That notice stay-at-home orders don't fall in line with that constitutional level of scrutiny. So we're going to see some of these things play out, right? We're going to see that, you know, we know that this COVID-19 is not over and done with, right? And what are the policies and procedures that we're going to have from moving forward? And which one of those are going to be challenged in the court? And where is the court going to put this kind of thing, right? How much is it coming at people, right? Or is it going to be moved? Are we going to say, well, even though it goes for the whole population, that's not okay? What if we actually were at the point where we could make just communities stay home, like individuals in neighborhoods, because they are the ones who had it? We would then be maybe moving up into these other classes, right? By saying the whole city or the whole town or the whole state has to stay home, we keep ourselves at that rational basis. But and we have to be really careful, because if we start to say, and this is part of the idea, think about the contact tracing, right? And, you know, even the idea of using the app, that's an individual liberty issue, right? But let's say we were able to do, let's pretend the United States all of a sudden decided that that was a great thing to do and we were all going to participate and it was going to work perfectly. If that's the case, right, what if then it identified this little community of people that had COVID-19 and they were supposed to stay home? Now we're actually implying some sort of government intervention that is not applied to everybody. And then would the government be allowed to do so? Well, we don't have the answer to that just yet, right? But it would be something that we would have to think about if that was our policy, right? Policymakers would have to be very careful about putting classes of people, whether they're communities or particular, because think about communities, how they're broken down, especially in large areas. You know, there are communities in race, right? This is the Chinatown part of town. So what are you able to do that and allow it to be more constitutionally acceptable? Will the court, okay, but it's okay, it's still, because they can still say it passes the test. if the government didn't do it on purpose to narrow that group out for a reason, right? If they said, well, here's the reason we did it, because they have 300 cases of COVID and no one else in the state has any, that was our legitimate government interest, and that still could pass even though that's strict scrutiny. So we'll just really have to see how this stuff plays out. Again, it's important for us to be thinking about this because a lot of you are working at a local health department. How do you know what to do? You should be looking at this. What are the policies? What are the procedures that you're using? And do you have authority to do so? And then, you know, which of these levels will that fall under if it's not just a blanket policy? Because, you know, a lot of people I've heard, you know, have been talking about the idea that maybe at some point we can just shut down pieces. But again, I'm not sure constitutionally that we can get away with doing that without shutting down whole areas at once, unless we can pass that strict scrutiny. And the Supreme Court's probably going to have to jump in and talk to us about that before we can go any further. So how do we do this? It's a balancing act, right? So at the heart of public health laws are these struggles to determine the point at which government authority to promote the population's health has to yield to individual constitutional rights, okay? It always comes back to that community or that government intervention versus the individual interests. So it's interesting because for much of our country's history, the balance was weighted in favor of public health because we had so much disease and pandemics, and you know, we had this back in 1920. So countless court decisions through the early 1900s actually found in favor of the state or the local government if they were seeking to protect the public's health, sometimes to the detriment of individual rights, right? Courts justify these decisions in part by the strong need for public health measures to control infectious disease, right? And chronic conditions, things that there were no cures for that were affecting huge parts of the population. Public health actors were granted significant deference to stymie these threats to the health and the economy. But other legal factors were also at play. So remember when we first started talking about the Bill of Rights is what gives the states that power, right? But they hadn't really recognized necessarily that all of those applied to the states. It wasn't until we added that 14th Amendment that all the Bill of Rights actually began to be applied to the states, okay? So the 10th Amendment says if it's not in the Constitution, the states have purview. But the Bill of Rights, that first 10, those were never applied to the states until we passed the 14th Amendment, right? So First Amendments didn't fully apply to the states until 1925. You didn't necessarily have a First Amendment right within your state because it didn't apply, okay? So we have to think about part of the reason that there was a deference to these things is because the states didn't have that kind of power, or the states had more power at the time because they weren't having to go by those Bill of Rights. So individual liberties were easier to walk on back then. Of course, one of the biggest cases, the most often cited cases in public health, is Jacobson versus Massachusetts, right? So the Commonwealth, just for a refresher, I'm sure that name sort of rings a bell. What is that court case and why would I remember it? The Commonwealth of Massachusetts legislature enacted a law that said local boards of health could require vaccination of residents if necessary for public health or safety. So they were facing a potential outbreak of smallpox. So the City of Cambridge Board of Health, the Board of Health, mind you, issued a vaccination requirement in 1902 that every person had to be inoculated or had a $5 fine. Now, of course, in our day and age, $5, but back then in 1902, $5 was quite a hefty fine, right? So Jacobson refused to get the inoculation and he sued. Well, the Supreme Court rejected him and said that they looked at it as more of a community-oriented approach in which citizens owe each other and society as a whole. So Justice Harlan actually wrote this, and this is a direct quote from Justice John Harlan in his writing of the court case, Jacobson versus Massachusetts. And he says, the liberty secured by the Constitution does not give us an absolute right in each person to be at all time and in all circumstances wholly free from restraint. There are manifold restraints to which every person is necessarily subject for the common good. On any other basis, organized society could not exist with safety to its members. In other words, efforts to address communicable diseases, for example, might include an education campaign. So like a family planning center offering voluntary sex education classes. So you could come to them if you want to. You're not required to do so. If you have a vaccine drive, right? So I know some of you, you know, we've been reading, we see that vaccination rates are dropping because people are afraid to go to the doctor's office to have their kids vaccinated, right? So a lot of communities are getting clever, right? They're taking those vaccines on the little bus, right? And they're doing vaccine drives, going to people's places, right? So that you can get that, but it's voluntary, right? You're not being required. It's not showing up and knocking on your house saying you must do this. It's giving you an opportunity to not come to the doctor's office to get it done, right? Also, testing or screening programs and treatment options could be that. And so in this case, individuals just seek out that information or their public health services on their own, right? So anytime we say voluntary, that's what it's meaning. We're giving you the option. Here's your choices. Here's the things that we can do. So that's one type of power, right? By just offering it, we're actually using a power there, right? Because we're giving them the option of doing so. The next step, and so these next two are fun because people sort of think of them as the same thing and they're not. So the next one is mandatory. This one sort of raises the stakes, right? When it's legally authorized, practitioners can implement public health interventions that no longer seek voluntary actions from individuals. Instead, they're going to set conditions on participation to encourage or require people or groups of people to protect the public's health to avoid penalties. Requiring citizens to be vaccinated or else to get a fine, like in Jacobson, is illustrative of mandatory, right? So anytime we have testing or screening or treatment programs that mandate individual compliance, subject to varying conditions, such as receipt of treatment or other services. Participation in a treatment program might condition on one's avoidance of a more intrusive public health measure, such as quarantine or isolation. In each of these things, mandatory public health powers are often challenged based on infringement of individual freedoms, even though individuals ultimately retain a choice. So here's the thing, it's mandatory. We still have a choice not to participate, right? Think about even the vaccinations that we have to have for our kids to go to school, right? Those are mandatory. Why are they considered mandatory? Because you just can't go to school if you don't have them, right? There is an opt-out still, even when we call something mandatory. My son's pediatrician, same way. You have to have your vaccinations up to date or he will not see you as a patient. It's mandatory. But your option is to not have him as a doctor anymore, right? So the last one then is what we call compulsory. Compulsory. So with the exercise of compulsory public health powers, choice is no longer an option, okay? The government doesn't offer a chance to participate to avoid a penalty or get a service or a benefit because you did. Your participation is by force, by any magnitude necessary, and these compulsory interventions require individuals to participate or change their behavior irrespective of consent. And you think, my goodness, when would that ever happen? Well, in the 1900s, it did, it happened. In New York City, public health officials went door to door and forcibly vaccinated adults against smallpox. So we have seen this happen. Would we see it happen today? I don't know, right? I think we'd get a lot of pushback if we paid any attention to the protesters in the last 2 weeks. We see that citizens aren't really necessarily under compulsory type powers, right? So this is compulsory public health powers are seldom used today, right? Because they really do run into what we call public health ethics, right? And again, we didn't necessarily have that ethics code. It's interesting for me to think about it now. You know, we look back at these kind of things when we talk about the Tuskegee Airmen experiment, when we're looking at, you know, giving groups of people, particularly African American males, you know, syphilis and just to watch to see what happens, right? And no one was saying, how can you do that, right? So we weren't at that place where we had this set of public health ethics. So things like showing up at someone's door and giving them a shot whether they wanted to or not, we're just seen as, hey, we're protecting public health. Again, today, we see that that's gone too far, right? We do, thank goodness, have that public health ethics to keep us, hopefully, from making those kind of mistakes. But exercise of compulsory power might fail to survive constitutional scrutiny, even if the government has a compelling interest, because you could do something less restrictive, right? You could do something that's mandatory. You could do something that's voluntary. So how do you get to that point that's compulsory? So even though there's these three types of power, really what we're looking at using are the voluntary or the mandatory, right? And how do we get people to do this and be part of it? And which one of these should we be considering when we're talking about creating a policy for our issue, right? But we do still see it, right? Think about this. If we have forcible testing of persons charged with criminal transmission of HIV, right? They have to have the test, right? Because they have to be able to determine which other individuals might be exposed. So if you're charged with criminal transmission of HIV, right, you are tested. whether or not you so choose. Do so with your choice, okay? All right, so let's look at the next piece here. Social distancing, yay! Which is so funny, right, to a layperson, and some of you in public health may have already talked about this in this way, right? But social distancing has become the new term, right, that we've all gotten used to during a pandemic. But this is actually a long-standing public health power, right? Social distancing. Social distancing, they have powers to test, to screen, to treat, and to vaccinate. Another slate of powers are available to control communicable conditions, which of course is nice and relevant to us today. Social distancing powers include the following, right? Quarantine, isolation, curfews, closure. Who knew we had these powers, right? Well, we do now, right? But these have been around. These are not new, right? We put it all together and talk about social distancing as in 6 feet away. But that term comes from this idea that to protect the public's health, we do have these tools in that toolkit: quarantine, isolation, curfew, and closure, right? Now, these aren't supposed to be punitive per se, right? We're not doing these things to hurt people. They're designed to limit the spread of airborne or other easily transmitted conditions, right? These powers are still if we turn to these when other interventions are unavailable or ineffective, like for instance, what we're seeing now, right? So this is really interesting because typically when I cover this section prior to this year, everybody's like, wow, we don't use that unless, you know, somebody's super sick or we've got, you know, pertussis outbreak or something, we tell them to stay home and isolate, right? We don't think about curfews or closures. Literally, I've seen all 4 of these things happening, right? Think about it. And again, I live here in California, in a nice little city called Claremont, but I'm about 35 miles east of Los Angeles, but I'm still in LA County. So not only were we under closures, right? Restaurants not open, whatever, we're at stay-at-home orders still. We're slowly moving in the other direction, but we've been under this since March 13th. But again, anybody who has any suspect of having COVID-19 goes either isolation or quarantine, depending on whether they've been tested for it or whether they just think they might have been exposed to somebody. We've had the closures, and due to the riots, we've actually had curfew. We spent 5 days 2 weeks ago under curfew, again, not for the public health per se, but to keep people safe, right? To keep people safe and off of the streets. So, like I said, a year ago when I talked about this, you know, students were saying to me, gosh, we don't use any of these things, and here we are right now. So it is important to think about all the different powers that we have and are able to do these kind of things. So sometimes federal health or state authorities might be authorized legally to apprehend or isolate somebody carrying any number of highly infectious conditions. However, in practice, typically we want to look at the ethical principles of doing so, and we want people to voluntarily comply, right? Think about this. If we say, hey, if you know you've been around someone who has COVID-19 or who might have COVID-19, can you just stay home for 14 days? We need you to do that, right? Or if they're not at the point where they need to be hospitalized, right? If they do have COVID-19, we ask them to go home and stay, quarantine themselves away from everybody else. So that's that voluntary power that we're using there, right? We're not putting a guard outside their door. We're hoping that they'll go with this voluntary power that we're using to do that, okay? Because partly because of the ethical principles, partly because the constitutional rights, right? So again, we also have the right to travel, but curfew orders could be necessary. We know the president has said you can't leave the country to go to certain places. Even though that right to travel is constitutionally protected, it can be curtailed when a community has been ravaged by anything from floods to fires to disease, or if safety and welfare are threatened. That's how they can use a curfew. That right to travel can be curtailed, whether it means travel outside the country, outside of the state, or whether it means curfew as in you can't be outside of your house. Intrusions on personal liberties, though, that come from these social distancing measures really vary, because of course they're restricting movement, right? We really don't want to do that unless we absolutely have to. And we've seen, right, in the last few weeks, how much people push back when we tell them that they have to stay at home, right? Notice everybody was pretty much okay with voluntary, and I say most people, you know, when states put the stay-at-home orders in place, lots of people were able to stay home, right, for 2 weeks. 2 weeks they were fine with it, right? And then we started to see protest after protest after protest about being able to go back to work and the right to work and the right to go provide for their families, right? We saw what were we hearing there? We were hearing that individual liberty coming out. And again, the justices would have argued back in the day that they're forgetting their social contract, right? That you staying at home actually then protects other people around you. It's sort of like wearing a mask, right? We know that you wear a mask, we wear a mask, and we're protecting each other in that same way. But if we can't get people to do that, and again, most of that's voluntary. I mean, now there was a couple cases in New York where people were getting fined for not having their mask on, but for most places, you don't see officers running people down in the street because they're not wearing a mask. We're putting that policy in place, but it's still part of that voluntary power. Okay? So to support uses of coercive public health powers, public health authorities have to be prepared to demonstrate a lot of things. That the subject of social distancing is actually or reasonably suspected to have something, an infectious condition. The subject has to pose a specific threat to others' health. So of course you can temporarily quarantine a group of people after their exposure, such as smallpox, right? If we found out this group of people had smallpox, we put them there. We saw this in New York, actually, with the Hasidic Jews population when they had the measles outbreak, right? We quarantined that group of people. And again, that would fall under what? That would be strict scrutiny. But the ability to pass that to other people was too great, okay? So the government was actually able to do that to isolate them. We see it when we isolate nursing home residents to prevent spread of infection, right? We're seeing it with the restrictions to not let people into nursing homes at this point in time, right? So also, if we're going to isolate somebody or quarantine somebody, we have to make sure that the place we're putting them is safe and habitable, okay? Because that doesn't always happen. Literally in 1909, the South Carolina Supreme Court struck down a quarantine order because there was an older woman who had leprosy, and she was removed from her little cottage home and put in a place that had pests, and it was coarse and comfortless, she said. And so they couldn't do that. They could make her stay in her own little cottage, but they couldn't remove her and keep her away from other people by putting her in someplace worse than where she was. So, and of course, individual or group confinement, it can be warranted, right? Just like I mentioned with a measles outbreak or a smallpox outbreak, if we had something like that, we can do it. So again, would that be enough for us to quarantine just groups of people who had COVID-19? It sounds like that might be the case, right? But again, we would have to see, does that individual rights, is that going to supersede that when it comes to that disease? And who are we asking to put in quarantine, right? If we're hitting that race, that gender, that sexual orientation class, is that going to cause us some legal standing aspects for doing that, okay? So once we've passed that legal issue, right, we're still questioning how to choose an option, even if we know we can pass the legal test. So we've gone through the policy process, we've analyzed our policy options, we've got 3 or 4 on the table, and we say, okay, these 3 right here are gonna pass, should pass legal muster, okay? But now, how much do we wanna have as an intervention, right? How strict, how forceful, how much do we want to intrude on individual liberties? We can actually use the intervention ladder to help us to do that, okay? So let's look at this. This is a great little useful tool for us. Here's the intervention ladder. And you can I just grabbed this from it says Biomed Central, but if you type in intervention ladder, it'll pop up in about 10 different places. I did include this in your handouts just so you have it as a reference guide to what we're doing here. So intervention ladder, right? Here are 1, 2, 3, 4, 5, 6, 7, 8. There's 8. There's 8 choices here, okay? But we're gonna look at them we're actually gonna start with this 2 and number them 1 through 7, okay? Because why? The first one is to do nothing, or just monitor the situation, okay? Which of course, monitoring is doing something, okay? But that's not necessarily intervening, right? So that's the base. So I'm calling that 0, okay? 0 is do nothing. So we're gonna number these then as we move up from 1, 2, 3, 4, 5, 6, and 7. And as we do this, think about this. So the second thing we can do is just give information. And then the third part, the third choice on the intervention ladder is to enable choice, or the second, I'm gonna say the second, enable choice, right? So you're allowed to change your behavior, Okay, so that's a policy option. We can give people a choice, right? And then we might move up one more and guide that choice by making the default a healthier choice, right? We make it a healthier choice. That maybe our policy is that we're going to provide a healthier option. And then maybe the next thing we need to think about is we could use financial incentives to get you to do something, right? Now this is like to give you something, right? Because the next one, if we go up, look, that's a disincentive, right? We use financial or other disincentives to influence people. So this would be like we taxed you, right? Taxed you. So, and then the next level is to restrict choice. We're going to regulate to restrict the options available to people. And finally, we eliminate your choice completely, okay? We eliminate our choice completely. Okay, let's go ahead and look at these individually and see where we came out. At eye level, if that's our policy to do that, and above other options, right? So the majority of you said that it was 1, 2, 3, making the healthier choices a default option. So yes, that's it. That's where we would fall right here. So we've actually jumped up a couple ways, and we're guiding their choice, right? Because we know if we put something at eye level, that's what they're going to seek, right? So they're able to do that. So that is, in fact, where it would be. So on the intervention ladder, where do vaccinations required to attend school? Where would this be, right? So we're not eliminating choice altogether, right? Because they do have a choice not to vaccinate because they could stay at home, right? You could stay at home and do homeschooling instead. We do actually see that. So we're restricting the choice, right? We're regulating to restrict their options. They must be vaccinated or they cannot attend school. Okay. The next one is the cigarette tax, right? Cigarette tax 1, 2, 3, 4, 5. Most of you got that one, right? So we're guiding choice through disincentive, right? We're using financial burden to get people to do so. And the next one is where on the intervention ladder does sex education programs fall? Of course, that one's down here, providing information to inform and educate people. Now, you could see it as enabling choice to change their behavior, but typically it's not necessarily to change their behavior if we're in education school, because hopefully we get to them before they've had any behavior. So really at this point, we're probably looking at hopefully providing this information to keep them from making some poor behavior choices, right? Where on the intervention ladder are the needle exchange programs? There's a little bit of disagreement on this. So options 2, 3, and 4. Where would we be, let's see, on needle exchange programs? So 1, 2, we are enabling choice for people to change their behavior, right? Guide through making the healthier choice, right? This is fall for the needle exchange programs. And then a couple of you actually put through incentives. Now, typically we're not seeing financial incentives, but again, you could make an argument for any of the things that you just said. How far are we actually going? We know for sure that we're giving them choice, right? We're giving them a choice to change the behavior. Healthier options, I don't know if a needle exchange program, I guess, I mean, you can see it as healthier because the needle is not dirty, right? But unless we're actually moving them out of the needle exchange and into some sort of treatment program, then that would actually be helping them for sure to make healthier choices. And we might be giving them incentives to do so. So notice how, depending on what we include in that needle exchange program, would be how far up this ladder it would go. Again, as always, anytime we use anything, models, policy, whatnot, any type of model is always subject to interpretation, right? But at least we can start to think about, as what we really want to use this intervention ladder is not necessarily to be right or wrong, because again, part of us could argue along this ladder. But we want to think about that every time we take a step, we're actually restricting people a little bit more, okay? We're looking at that individual liberty. Even if we're trying to do it through making a healthy option, aren't we still trying to restrict their choice at some point to take the water instead of the soda, right? So that's really what we have to stop and think about here is, so this is a useful tool to sort of think about, okay, wait, where am I at on this ladder? And have I gone too far? Because the court's gonna ask, right? Were there other alternatives? Were there other alternatives? So of course, if we think about those sources of power, right? Eliminate choice, that would be our compulsory. If we start, we'll go to the top and come down. The mandatory would be to restrict the choice, right? And also mandatory probably even could be considered this disincentives, because if you're making people do something because you're financially squeezing them, right, to do so. But the rest of those are all fall into some sort of voluntary, right? So notice how when we talked about the powers that we said we typically try to do voluntary. So even when we're moving up the ladder, we're still trying to use that voluntary power, okay? All right, because we have to think about these ethical things to consider, right? So thank goodness I said earlier for ethics, right? Ethical things to consider. So there are 6 steps that we can sort of think about. And this really, there's just 6 things. We're going to look at them quickly because we're going to move into the next piece of it, and we can actually see why this matters, okay? So the first one is that we want to identify the goals that aid in decreasing morbidity or mortality. This goes under that rational basis scrutiny. Remember when we looked at it before, it said that the goal of public health is to decrease morbidity and mortality. So if we're identifying goals and policies that are doing that, we're already starting off on the right ethical foot, okay? The next thing is we have to determine whether their data exists that indicate that our tactics are going to be effective. So does our policy have a leg to stand on? Have we seen this? Are we just pulling things out of the air that we might try? Or do we sort of have something ethically to stand on? Could we pull from other people, not reinventing the wheel? Do we have data? The next one is to consider potential burdens, particularly when we're talking about risks to privacy, liberty, and justice. Again, this is a good thing to think about both public health law, the levels of scrutiny, and also that intervention ladder. How far up that ladder are we trying to go here, right? We want to examine whether alternatives would mitigate these burdens while maintaining effectiveness. In other words, is there a policy that could be less restrictive to all these? Or are there burdens to a potential group that we need to mitigate, right? Did we distribute benefits and burdens fairly based on data rather than being arbitrary or stereotypical? And finally, do we analyze whether the benefits outweigh the burdens? Now notice when we look at these ethical steps, 3 through 6 mention benefits and burdens, right? Number 3, potential burdens. Number 4, mitigate burdens. Number 5, benefits and burdens distributed fairly. Number 6, benefits outweigh the burdens. So when we're thinking ethically about creating a policy, we're also thinking about who gets the benefit and who gets the burden. Now, very clearly, before I go any further, when you create a public health policy, someone will always get a burden, okay? We cannot create a policy in which somebody is not going to get a burden. When we're considering policy options, then we have to think we have to identify, we have to make very certain that what we have identified as who gets the burden is not so egregious, is not in such a lower socioeconomic status, is not so much so that they're already on the streets, that we have given them the burden on top of what they already have. And a good way for us to think about this is actually to use Snyder and Ingram. Okay, so Snyder and Ingram actually have a book. It's called Policy Design for Democracy. But a big part of their book here is actually using these social construction examples that show sort of how we think about people when it comes to making policy. Okay, now none of us like to put people in boxes, but this is actually a very useful tool. Okay, and we actually can look at this over time, and it's been used and applied to different policies and how people were able to get passed, right? You have to think about politicians, who has their ear, right? And in this social constructions, now, before I go too far, this is the original. It was actually in an article in 1993. Now the best part, any policy model that can be useful and used is good. But another piece of a good model is one that can be amended over time. So what actually you will see is that we see people moving within these 4 categorizations, and we see that some things are missing. We think, wait, like I don't even see homeless on here. Where's the homeless population? Where are those people on here, right? So in your handouts, you actually have what I called social construction examples, and it sort of shows the evolution of the social construction table. There's several other examples that have been used all the way up through 2016 to sort of show us how this has shifted over time. And again, that's not a bad thing. That's not showing that this doesn't work. That's showing us that we have the capability to mold it and keep using it as things change in our society, okay? So we're looking at this and we think, okay, a couple of things. One, if we look at the across ways, right, this is our power, our political power, okay? So the top row is strong. People who are considered advantaged or contenders have a lot of political power. So they have the ear of those politicians, okay? They have the ear of those who are sitting on the Board of Health. People at the bottom row, dependents and deviants, they have weak political power. Basically, nobody's listening to them, okay? And then we look at this, and the column actually shows us positive, right? That's people that are thought of positively in a community. And then the other column is negatively in a community, all right? So there's 4 different categories here. We have advantaged, contenders, dependents, and deviants. Those are the 4 categorizations. And notice in this example, again from 1993, so the elderly, business, veterans, scientists were advantaged. Contenders were the rich, big unions, minorities, people who were moving up. And we're going to talk about like how do they define those in just a second on the next slide. But again, we can move these, and they're not perfect, right? Because you could be in more than one classification, right? So what if you are a disabled elderly? Are you just in the disabled category? Or are you advantaged because you're elderly, right? So again, not perfection, and of course seems very stereotypical, but the problem is policies typically follow stereotypical lines, okay? And we've seen it time and time again. So it's really important for us to sort of stop and think about who in society fits in these categories, okay? We have to think about that when we're developing policy. So if we look at the next slide, here's what their definitions are, okay? So if you're advantaged, you're treated positively in public and you get benefits publicly. Politicians have no problem giving you something, an advantage of something, because you fall in that line of people who are treated, you're advantaged, right? Now contenders still have some power, but they're the ones behind the scenes, negotiating privately to get some of those benefits, and the politician's not going to run out and say, yes, let's do this for this group of people. And of course, dependents, they're treated positively in public. Who doesn't want to think about the poor kids? But they're not able to mobilize to get themselves more benefits. And then of course, deviants, well, I mean, the board itself tells us that they're treated negatively and they're punished by policy, right? And this figure 2 on the side here sort of shows you both the front. This is where the benefits lie, and there's where the burdens lie. And so basically what the argument is this, and again, you have this so you can look at it in more detail later. If you're advantaged, right, you're going to get a lot more benefits and you're going to get way less burden, okay? If you're a contender, you're going to get benefits, but they're going to be in secret, right? You're going to get some burdens, and actually what we find happens is the contenders, they may be given a benefit, but we will be sure to tell people that they're going to get the burden. Because we want to see that they're not advantaged. We want to make sure that people understand they're still in that contender category. When we get to dependents, same thing. They're given some benefits, but not to be what they should, right? We haven't covered every kid everywhere for everything. And of course, that means they also are given burdens more than they should be as well, based on our policies. And then if we look at the deviants, right, they have no control. Benefits are very under-described. Burdens are over-described. Because once you get to that, ooh, you're the bad category, right? Who's making any policy that benefits you whatsoever, and how often are you being burdened with that policy, right? And so we need to really think about who is fitting in these categories. And what's interesting is, like I said, people move over time. That handout I gave you with the social construction example sort of shows you how it evolves constantly, and we could probably even change it today, right? But we also, what's really useful about this tool is we can look at it in terms of how we can do this, okay? So we want to talk about the impacts of this, right? And again, I'm not going to cover this entire piece of this, but I want us to look just here at the top. Whether you're advantaged, a contender, a dependent, or a deviant, here's what we're thinking about. Here's the message. What we're trying to say is that your problems, when we create policy, this is basically what happens. If you're advantaged, we say your problems are good, intelligent, important public problems, and the government's going to treat you with respect. And your orientation towards government is supportive. Now, if we look at contenders, let's think about this, right? And again, I would argue that sexual orientation falls here in contenders category, right? Because your messages, your problems are controversial, in conflict with other people's interests, and the government should treat you with spirit of caution. Right? Do we see how that works out? We see how we can put people in those categories. Again, if you're dependent, your problems are helpless, you're needy, and it's responsible as a private sector. We're supposed to take care of you, and the government should treat you with pity, right? And of course, if you're a deviant, your problems are bad. It's your own responsibility to fix it. The government treats you with disrespect or hate, right? We think about people who would be put in those categories that would get policies that go like that, right? We know that that happens. We know that people get benefits, and we know that people get burdens, right? So we want to be able to think about that when we're creating a policy. For instance, right, if we take a tobacco tax, right, the whole goal of a tobacco tax was absolutely to get people to reduce the amount of smoking. But when you place a tax, if we think about the people who are smokers, right, many, many, many of our smoking people are people in a lower socioeconomic class, right? So what was the burden then? The burden was they didn't get the benefit, right, unless they were actually so burdened that they actually had to give it up. But what we typically saw was that people maybe cut down, but then they were burdened with even more cost when they already didn't have as much money. And of course, we created a policy that was not what we wanted to do. That was not the point of what we were trying to do. We weren't trying to put them in a worse situation. We were thinking of their health. But that's not the way that it came out, okay? So what's really cool is here. Not only can we do it with groups of people, but we can also do it with an issue, okay? We can do it with an issue. So I'm gonna do this. Here's what we're gonna do. I'm gonna show you one, then I'm gonna give you one real quick for your turn, and then we're gonna take a short break, okay? So let's think about immigration. All right, so we have our 4 categories here. And like I said, I'm gonna go through this one really quickly with you, and then you're gonna get a chance to do one real quick on your own, all right? So in this case, we have to think about it. Immigration. Now, immigration, again, one of those big issues that can mean lots of different things to people. So here's what I did. I just came up with 4 little categories, 4 things that could fit, right? But when we think about immigration, who do we mean? Do we mean dreamers? Do we mean people who are legal immigrants? Are we talking about illegal immigrants? Are we talking about small kids of immigrants, right? So if we're looking at this and we're trying to put these into categories to see how we might be helping or hurting them, where do you think these would go? Right, I'll give you just a second. I'm gonna give you the answer to this one. You get to answer the next one yourself, okay? Think about that. If we're thinking about immigration, we're thinking about making policy that's going to impact immigration. Okay, so the advantaged are the legal immigrants, right? People who came here legally, people who followed all the channels, mostly people that are from Europe, right? We saw lots of people over there. Now, it's not that we don't have legal immigrants from all over the rest of the world, but look at who gets those advantages, right? Early on, people who were coming to this country, who came here legally, went through the proper channels, those are people who are advantaged. They get benefits in policy. Contenders, I would argue, would be the dreamers, right? Those are kids who are now college age and moving into that millennial type stage, right? Who have been here probably since they were too small to know any better, right? Who are fighting for that chance. They're contenders saying, hey, we should get to count because we didn't have a choice, right? And of course, dependents would be our small kids of immigrants, right? We take care of them. We put them in public school systems. Right, we make sure they have vaccinations. Why? Because they're dependents. They're still small children. Even though whether their parents are illegal or legal immigrants, right, we're still taking care of them in that way because they're dependents. And then finally, of course, the deviants in this model is obviously those who come here illegally, right? And we do everything we possibly can to make them not be able to do it that way because they're considered, so they're getting the burden rather than a benefit, right? Makes sense. So this model is really great because you can apply it to groups of people or to an issue, right? And of course, you don't always have 4 categories. You may be missing one because maybe your policy doesn't have anything to do with kids. But maybe somebody is a dependent in there that may not be a child. Maybe it's a mental health person that would still be considered a dependent. So I'm gonna give you, like I said, this example. I'll give you just a couple seconds to think about it. Homeless populations. Now, I'm even gonna be nice here. Think about homeless populations. Who, and you're thinking, how in the world could we think about anybody being advantaged or contenders in homeless populations, right? But I'm going to give you the choices. Now, again, I did not include everybody. I wanted to make this relatively painless as we were going through it. Okay, so here are, this time I gave you 6. So clearly some of these are going to be, you know, there's going to be more than one answer per category. So just think about that for a minute. Where would you put these, knowing what you know now, right? Advantaged, contenders, dependents, and deviants. For each of these 6 categories, which one of them would you put them in? And I'm going to give you just a minute. Like I said, if you have a piece of paper yourself, just jot it down. I have a poll for this one, and then I'll pull up the answer in just a second, but I'll give you a minute to sort of think, where would you put those? And again, when you're putting these in the categories, it may be a matter of even your own community, right, looks differently. Is it, I mean, that's a really good way to think about that. Again, and we don't want to think about it personally, because I always make the assumption that for the most of us in public health, our goal is to help the overall population, right? So we're not necessarily, we don't want to put people in boxes, right? We don't want to put groups of people in boxes, but we have to think about it when we talk about policy development, because politicians are, the society is doing that. And when that happens, politicians react to that way and giving benefits and burdens, right? But this might even be changed as we look at what I have the answers here in a minute. This might be changed even in your own community, right? Because think about that, different parts of the country, different communities look at people differently, right? So if you don't get the same thing I get, that doesn't mean you were wrong, right? It just means that where I sit, right? And policy adage is this is a really good line for the day. Where you stand depends on where you sit. Okay, so in other words, where you stand on something, where your side of the issue is, depends on your seat at the table. What do you see from your purview? Okay, so let me go ahead to this really quickly. Here's where I would put them. Again, this is just based on my immediate understanding of how we sort of take care of people. If you think about the policy, and again, I have huge homeless population here in LA County. So those who recently lost their job, right? Those are the ones we feel bad for. Those are the ones who are advantaged, right? Those are the ones who we think they could potentially go back to work. So we want to help them get in a house, right? We want to make sure that they don't stay homeless because they couldn't help it. It was COVID-19, right? The contenders would be the veterans, right? They're not advantaged. If you're a homeless veteran, you're not in that group that people are overly looking out for. I mean, look how much trouble we even have with the VA trying to get regular care for them, let alone if they're homeless. But there's that piece of society that says that they've fought for the country, okay? So we can't just throw them out per se, right? So I would argue that's your contender group in this case. Of course, our dependents would be our kids experiencing homelessness, or anybody with mental health issues. That would be those people that we're trying to protect, you know, the most as a society, right? If we know of kids who are homeless, even mental health issues, right? Like not necessarily fault, right? Think about that. When we put that fault word in there, we're starting to categorize people. And then of course, deviants, those are the ones who are habitually unemployed. That's when you hear people talk about laziness, right? Or when you talk about, oh, they're addicted to drugs. If they weren't on drugs, they wouldn't be homeless, right? But if we think about this, we actually can see how the policies are different based on which category you're in, right? And how people perceive them. And this has changed over time, right? It used to be, if we said homeless, everybody was considered bad. They were just lazy. But we have learned to see that there are actually several different pieces to our homeless populations. And I would argue that you could then put them in the categories, okay? So does anybody have a question on this? Because if not, we're going to take a short break, and then when we come back, we're going to do something fun. We get to do a case study, okay? So while you're on your short break, go ahead in your handouts that Emily sent you this morning, and you should have what's called the SSB case, okay, the SSB case. So what we'll do is we'll take a short break, and then I'm going to let you have it like 10 minutes or so, or whatever you need. If you need a little longer or a little less, go ahead and read that case study after you take your break. And then we're going to put you in breakout rooms so you can discuss the questions. So you're not answering the questions yet. I just want everybody to have a chance to read it without having to be in a breakout room with somebody else. But we'll go ahead and put you in one as soon as we finish. So go ahead, take your 5-minute break, and then just be sure you pull that up, that case study, and I'll come back and give you some sort of direction on that, and then we'll move in that direction, okay? Hopefully everybody had a chance to take a quick break and are able to pull up that first case study on what I'm calling the SSB tax, sugar sweetened beverage. So I'm going to go ahead and give everybody 10 minutes or so. If you need a little less, a little more, we'll probably ask you. I'll have Emily send a poll out in, I don't know, 7 minutes or so, and see if everybody's done. And if you're not, just say no. We'll give you a couple more minutes before we put you in breakout rooms.